here this morning. As we're all aware, October is Breast Cancer Awareness Month, and we have one of our healthcare experts here to talk to us about genetic counseling and testing. Our featured speaker, his name is John Neary. He's a licensed genetic counselor at Hartford Healthcare Cancer Institute. So he's going to give an overview of genetic counseling. Of course, if you have any questions, we will give time at the end. John is kind enough to leave some brochures and his business card and information over here. And just as a reminder, we have coffee, water, so help yourself. And thank you all for being here. Also, we do have the November flyer available as well that you can grab if you didn't get a chance to. And thank you again for being here. I'm going to pass it over to John. Thank you.
Thank you. Okay. So again, it's nice to be with you guys here today at the West Farms Mall during Breast Cancer Awareness Month. I mean, in general, as I talk about genetic counseling, I usually start by explaining it's always a discussion that I would really be having with a person. And so I do mean to have a pretty active Q&A at the end of this talk, actually. So if you do have questions, please feel free to write those or yell those out at the end of our lecture here. And in general, what I'd want to do with you here this morning is kind of explain the genetic counseling process and then talk a little bit about DNA testing and what might trigger that process. So, to begin, I usually like to explain to people that I'm a science guy, that I didn't go to med school. I'm really more of a geek. You know, my training was all in molecules and DNA and things of that nature. And so when I'm meeting with people, that's really my focus. Fortunately, at the Cancer Institute at Hartford Healthcare, I worked with extremely talented doctors and physicians and medical experts, and those guys are really going to tackle all of the medical details that accompany. Oh. I think I lost. Battery's dead. Fortunately, I can yell pretty loud, so. Okay. Okay, I think we're, no? Sorry. Oh my gosh. So anyways, what I was going to say is I work with some pretty talented doctors, and they really tackle all the medical stuff here. So when I meet with somebody, it's usually so that I can look at their family history and their personal history and then talk a little bit about what the DNA testing process is really about. I think here this morning it's usually helpful to talk about what DNA testing really is and a little bit about what a genetic counselor might do. So in general, when we talk about DNA testing, it's always helpful to review what DNA really is. We're made up of trillions of cells, and inside of those cells there are DNA molecules. It turns out that those DNA molecules really control the behavior of our cells. And in general, there are 4 letters inside of the DNA code. So there's letters A, T, G, and C, and those 4 letters together, they really spell out all of the information that our cells need to behave properly. There's a ton of DNA inside of cells. There's over 3 billion letters. So when I talk with somebody about DNA testing, I'm usually pretty clear with them. We are not going to do a full investigation of their DNA code. We're going to focus in on just the parts of the DNA that are relevant to cancer risk, right? It turns out that out of the 20,000 or so genes that are in the human body, about 50 of them should be preventing a cancer from happening. And so in general, when we do DNA testing for cancer risk, we're really focusing our efforts on just those genes that should be preventing a cancer in the person's lifespan. To do DNA testing, it's much more straightforward than you might believe. It's basically a spell check. We're looking inside of those genes letter per letter, and we're trying to make certain that the right letters are in the right order. And about 25 years ago, you guys might remember, there was a big human genome project in the United States. They were really mapping out the standard DNA sequence within a living person. And when we do DNA testing, we're comparing that person's results to the established baseline. All that basically to say that the testing is usually a straightforward blood draw. And all of that science kind of happens at the laboratory, and then we kind of wait for those results to come back and interpret those for the person. A key aspect for us is that if we do this DNA testing, we're really trying to find out if one of those cancer-fighting genes is working or is it broken. It turns out that some fraction of people, they actually have a broken cancer-fighting gene. A literal typo in the sequence of that gene is going to prevent it from working properly. And with that information, we might actually change the way that we do surveillance for the person. We might be able to change the way that we are treating the person if they have a diagnosis. And for me, as a counselor, we always focus on the family as well. You know, if somebody has one of these broken genes, it usually means they've inherited this from one of their parents. And part of my work actually is to help the family understand better. You know, if one of these genes is identified, this broken gene, who else in the family may have inherited this? And how can we help those people find out if they have the problem or not? And so I work at the Cancer Institute because I often get to meet with whole families over the course of some months, and that's a really rewarding aspect of my job. In general, the other kind of thing that we help people with is the billing process. So in general, I usually am able to help somebody get this covered by their insurance. I'm usually able to help somebody navigate that billing process. So I usually kind of think of myself as starting the whole genetic testing process and then also finishing that process as well. In general, when we do this testing, we're kind of reporting back to the physician who can help us understand what to do next. I'm not sure if there's any questions at this point, but I'd like to check in. Yep, we got one over here. That's exactly it. So all the testing that we're doing, we're trying to locate genes that ought to shut off that cancer process. They're really serving to protect us from cancer in the first place. In some ways, we think about cancer as being a genetic disease. You know, it's really what happens when a cell goes rogue. Sort of forgets what it should be doing, starts to grow and multiply and cause problems. I mean, that's really what a tumor is. And it turns out there's a whole network of genes that should be, stopping that inappropriate process. Yeah, I don't know if that answers your question. Yeah. You, sir?
How expensive would it pay?
Oh, that's a great question. So, 10 years ago when this testing was new, it was very pricey for the testing to actually happen, many thousands of dollars. But nowadays, in 2021, the technology has improved. If somebody wants to do this testing on their own, it's about $250 out of pocket. Much cheaper than it used to be. In general, though, if I'm doing testing for somebody for a medical reason, and there's a clear reason for that, it's going to be covered by their health insurance as well, maybe a copay. The only wrinkle is if there's a deductible. For some people, they haven't hit their cap for the year, and I can usually help them figure out what's going to make the most sense. Oh, yeah?
Yeah. You're talking about DNA test for generic gene broken?
Yes, broken genes, yes.
So is this only like a direct family, like siblings? How about the cousins or
yeah.
the descendants?
This is an
How
excellent
many
question.
generations?
Yes. So the thing I usually say to people is that if we identify a person with a broken gene, we know right off the bat they must have inherited this from one of their parents, right? It turns out we have 2 copies of every gene. We get one from our mother, we get one from our father. Well, if I start with one person who I know has a broken gene, my preference is that we test the parents and find out what side of the family has this broken gene come from. And then if we establish that it was mom's side, well, then I know that her brothers and sisters, they may also have inherited this from one of the grandparents. And so what we do is we kind of step out to those family members and we rule people in or we rule people out. And eventually, we might get to the cousins and even their descendants if we know that the gene has been traveling through that side of the family. We usually approach this in a stepwise fashion. And the thing I also say to people is that if you do DNA testing and all of your genes are normal, then you have no broken gene. We know that you could not, and very realistically, it's unlikely that a gene could be passed to the kids if the DNA testing is normal. So sometimes people will do this testing just to prove that they could not have passed on a broken gene to their children. Yeah, does that answer your question? Yeah.
Thank you.
Okay, yep.
So, how would environmental factors then?
Oh.
How does that?
Excellent question, yeah. I mean, the thing I would say is that only about 5% of breast cancer is hereditary, is caused by a broken gene or by a genetic risk factor. We actually feel that most breast cancer is either random, truly random, or caused by environmental risk. There are many people with breast cancer that I help get their testing performed, and we learned that there is no hereditary cause. And instead, we find that there's probably some environmental reason that that breast cancer may have occurred. Although when I say environment, you guys should know that also means lifestyle risk factors. That also means microenvironment within the cells. It's not just chemicals and things that we might come across in our day-to-day lives. Unfortunately, the problem with our testing right now is there's no test to find out what was the environmental risk. You know, we can do all of this testing of the person's DNA to find out if they have a broken gene or not, but there is no test to look at a breast cancer and say, what was the precipitating risk factor? How did that happen? I would kill for that testing, but it does not exist currently. Does that answer your question? Okay. And I think I saw a question over here. Yeah?
Yes, okay, my grandmother.
Yeah.
I learned that she had cancer.
Uh-huh.
But I don't know what type of cancer she
Yeah.
had. So, I have to get like a referral from my doctor to have the DNA tested done.
Yeah, I think in general, the thing that I would say is that if we're going to do DNA testing for a medical reason, it's always best to start with your doctor and ask them, does that make sense for me to do? For people who have family histories that are a little bit more unclear, that doesn't mean that the genetic testing is not possible. It usually means, though, that your insurance is not going to cover the cost of that analysis. And I usually also say to people, too, these kinds of broken genes are actually quite rare. Most of the time we do this DNA testing, we find out there is no broken gene, that there's no obvious problem. I sometimes do meet with people, though, who are adopted, for example, or they don't have very good details about their family history. They do the DNA testing because that's really the only way for them to gain some good information about what their long-term risks might be. And now that the price point of the testing has really significantly come down, it's possible for people to do this, and that wasn't true maybe 10 years ago when it was $8,000, $9,000 for the DNA test. Does that help you? Does that make sense? Okay. Other questions? Yes, sir.
Is the broken gene you will be able to detect when the baby born?
Oh, see, that's an insightful question, sir. These are genes that we inherit when we are conceived by our parents, which means that if you were to test a child, you would potentially be able to detect one of these things. However, I will say that there are strong guidelines in place to actually prevent the DNA testing of children. Whenever we do this DNA testing, we want to make sure that the person has the ability to choose to know these things. There are many people out there who actually decide they don't want to know that they have a genetic predisposition to cancer. They just don't want to know these things. And if you test a child, really what you are doing is you are taking away that choice from the child, and that is viewed to be usually not the best approach. We usually want to wait until somebody is 25 or 30 years old and then make sure that they have a good understanding of the testing so that they can really decide for themselves if they want to do it or not. I will say, too, that in the United States there are still some legal forms of genetic testing discrimination. So we know, for example, that there are good federal laws that protect our health insurance and protect our employment, but it turns out there are some legal mechanisms where somebody could be discriminated against if we knew they had a broken gene. So for example, if you get your own supplemental life insurance, you usually have to pass through a medical review before they give you a policy. If somebody has one of these genetic testing risk factors identified, that's going to prevent them maybe from getting the coverage. Unfortunately, I have met with young people who had the testing at a very young age and they were not warned that this would be a complication. They lose access to that kind of insurance. There are some other limited loopholes as well. If you're in the armed services, believe it or not, they would be allowed to discharge a person from the Army, for example, if they had one of these genetic risk factors identified. So in some circumstances, I do meet with young people and we decide it's not right to test them currently. We want to wait until they get older. And I will say, too, there is a mental burden here. For some people, they're just not old enough to really grapple with this, and we want to make sure that they have time to really process the information before they make a choice about testing. Does that make sense? Questions, sir? Oh, yeah?
So in today's technology,
Yeah.
is any way to fix that problem?
Oh, you guys are doing very well this morning, asking very good questions. So no, we don't currently have the ability to edit or correct these genes at the current time, although this is actively being researched. we can treat the symptoms maybe of one of these broken genes, but as of yet, we do not have successful gene therapy for many of these cancer predisposition traits. I used to tell people that I would probably never see this in my lifetime, but in genetics, we have a funny habit about being wrong on the timeline for these things. Even in recent years, there have been some big advances in gene therapy, and I think it's maybe one day possible that we might be able to correct this issue. In general, though, it's a very tricky process, to go into the cells and correct one of these genes. It turns out human cells don't like to be tampered with. They feel like they're under attack, like it's a viral infection. So you can actually trigger a lot of negative side effects if you try to do gene therapy without kind of a safe way to do this. You'd have to talk with a medical geneticist more, I think, to understand better how this might happen, but that's my understanding, yeah. Any other questions in the back? Yeah?
My maternal aunt had breast cancer.
Yeah.
And so I was offered testing.
Yeah.
And I go for my mammogram every year. I keep
Yeah.
So they offered me the testing, and I decided no, I didn't want the testing because I felt like it would be the sword of Damocles hanging over my
Yeah,
head.
exactly. Yeah.
And I figured I'd go for my follow-ups, and I didn't want that worry hanging over
Yeah.
because I'm that type of personality.
Right.
It's gonna be on my mind all
Yeah.
the time. So I just didn't get tested.
Yeah.
And I'm still here today.
Yeah.
Still going for me.
Absolutely. I mean, I will say that this testing is not appropriate for everybody. And we often find that, not everyone is interested in learning these kinds of things. And we often say to people, if you're working with your doctor and if you're doing, good risk management based on the family history, that's often perfectly fine.
You could have that broken gene and still never get breast.
Absolutely. Yeah. And in fact, that's one of the big caveats of all of this work that we do. There are many people out there with perfectly normal genes who still develop breast cancer later in life, maybe due to an environmental factor, and vice versa. I have met with women who are BRCA positive. We know that they have an elevated risk for cancer in their lifespan, and it just never happens to them. It seems to be partially random, even when you have that predisposition. So it's really been a big change in my field over the years. We used to really believe that if you had a BRCA mutation, it was almost a destiny type thing, where you would eventually have breast cancer. And over the years, we've just learned that that's not necessarily the case. We absolutely take it very seriously. We do screening based on this information, absolutely, but we don't take it as a guaranteed thing, yeah.
So do you have statistics?
Oh, yeah.
And what's the percentage and stuff? Because that was going to be
Yeah.
my question is, not
Sure.
everyone develops. the
Yeah.
cancer,
So, in the baseline population, about 12% of women are going to have breast cancer in their adult lifespan. Most people are diagnosed in their mid-60s. If somebody is BRCA positive, has one of these broken genes, we know that their lifetime risk is not 12%. It's more like 50 or 60% over the course of their life. So it's about 5 times higher. And we also know that the women who have this broken gene, they are more likely to be diagnosed at a young age. So in their mid-40s and sometimes even younger. If I know that somebody has one of these BRCA mutations, they're at risk, we would start breast cancer surveillance at 25. So it's something that we take very, very seriously. It turns out there are many genes that have to do with breast cancer risk, not just BRCA1 and BRCA2. Those are just the two most famous ones. All these other genes, they have their own statistics. They have their own risk profile. And we modify that surveillance guideline based on what risk factor is present for the person. Does that help you? Does that make sense? Yeah. And it turns out most of these genes, they affect multiple places in the body. So it's usually not just breast cancer. BRCA is a great example. We know that women with this problem, they may also have an increased risk for ovarian cancer as well. The same genetic risk factor that predisposes them to breast cancer will also impact the ovarian tissue. So usually when one of these risk factors is identified, we're going to want to make sure that we address each of these concerns. And nowadays in 2021, we have a good protocol for most of these genetic risk factors. We have a playbook that tells us when to think about these things and when to do them. Does that make sense?
So can you identify risk for other cancers? Would these specific broken genes relate to all cancers?
Usually every gene has a specific profile, right? So it's very uncommon for a person to find out that they're at kind of like global cancer risk all throughout their body. Most of these genes, they might affect, 3 or 4 places in the human body, and it's sort of uncommon for there to be very high risk for cancer throughout the whole system. I will say too that some cancers are really not felt to have a heritable component for the most cases. So like lung cancer is almost always related to environmental risk factors and not related to a broken gene that somebody would inherit when they're conceived. A good general rule of thumb in my field is that the more common a cancer is, the less likely it is to be hereditary. So for example, lots of people, they get little skin cancers as they get older. That is almost always related to sun damage, not with a broken gene. And on the other end of the spectrum, there are very, very rare cancers that might be 1 in a million, and those cancers actually have a high likelihood of being driven by one of these broken genes. Most of those are so rare, I don't talk about them though. Hey.
Okay, is fibroid cancer, is
Thyroid?
different from ovarian cancer?
Say that again?
Is fibroid
Oh, fibroid tumors, yeah.
different than ovarian
Great question.
cancer?
Yeah, I would consider those 2 different things. Uterine fibroids are actually pretty common. They're usually not felt to be dangerous in the same way that like an ovarian cancer would be dangerous. Although if you talk with a GYN, they'll have a lot more to say on this than I do. I usually say to people though, a uterine fibroid by itself is not usually concerning for like a genetic predisposition to anything. And similarly, people can have like benign breast tumors within the breast, and that doesn't necessarily mean the person is more likely to have like a BRCA mutation. We're really thinking about a true cancer as being potentially indicative of that. Other questions? Yes?
So there you can divide the broken gene into, severe, medium.
Yes.
and
Yes.
Is that will relate to how many times you'll get the breast cancer?
Well, yeah, we would kind of look at the particular change within the gene and try to find out, what is the level of function that that gene possesses. Most times we do this testing, we find out that the gene is totally broken and that there's no function remaining. That tells us that the person belongs in a specific risk category, and we do now have statistics about, what kind of cancers are likely to happen to them in their lifespan and at what kind of time periods. There are people out there, though, who they have a BRCA mutation and it's not totally disabling to the gene. They have some partial function there. And their risk level might actually be lower than a typical BRCA mutation, but still higher than somebody in the general population. Usually we're able to look at the specific spelling of that mutation and try to make a judgment on that. And that sometimes does help us with surveillance and risk management. Yeah. Does that make sense?
Is that true? People, the diet with a lot of cheese is more.
What's that?
The people with the diet of cheese or milk
Oh, yeah.
is more prone to the breast.
Yeah, there's been a lot of talk over the years about different dietary restrictions and, whether soy or dairy might impact breast cancer risk. I have to be totally honest with you, sir. I don't have a good knowledge base when it comes to those kind of dietary things. I usually recommend that people talk with their oncologist or maybe their GYN about these kinds of questions. In general, though, we usually say, all the boring advice that we give you at the primary care office, these are also things that would help kind of mitigate cancer risk. If you're at a healthy weight, if you exercise regularly, if you minimize things that we know are bad, smoking, alcohol consumption, these are ways that we can reduce our cancer risk. I don't know yet about, you'd have to ask your doctor about the dairy thing. I don't know. And then I think there was a question back here.
That was the question.
Oh, really? Okay, yeah. Yeah, it's a good question.
If you have a broken gene, you know that. How do you prevent it? What's the preventive maintenance?
Yeah, so that's a great question. Yeah, I think number one, we think about surveillance as being the most critical thing to do, right? So if we know that somebody, for example, has a BRCA mutation, we're going to want to do more breast cancer surveillance in general, mammograms and breast MRI. We know that some women who are at a very, very high level of breast cancer risk, they might actually choose to have surgery and remove their breast tissue. This is a way for us to directly prevent a future breast cancer. That being said, it's a very involved surgical process and it's not right for everybody. Usually when somebody is thinking about this, they're going to have a very thorough conversation with their doctors about whether that might make sense for them. Yep.
Is that what Angelina Jolie?
Yes, yep. And in fact, Angelina Jolie, she's BRCA1 positive. That's my understanding. So I think for her, she had the mutation. She had a very high-risk family history. That was part of the reason why She ended up doing that surgery on a preventive basis. As I mentioned earlier, though, not everybody might be at that very, very, very high level of risk, and so it might not be appropriate. And, we also take the age of the person into account as well. I think in general, we would treat somebody at age 80 differently than we would treat somebody at age 30. And, at the Cancer Institute, when somebody is moving through this process, they would really work with their doctors to determine what is the most appropriate way to kind of manage that risk. Surveillance versus surgery, and the timing for all of these things. Yeah. Does that answer your question? Yeah. Any other thoughts? Doing good? Oh, yeah?
If the cancer cell
Yeah.
has been surgically removed,
Yeah.
and then the broken gene still exists in the body?
Yes.
It does.
Oh, yeah. When somebody inherits one of these broken genes, this means when they're conceived, they get this, right, from one of the parents. That broken gene is present in every cell of their body. We know, for example, that if a woman is BRCA positive, it is possible for her to have breast cancer more than one time. That if we treat the original breast cancer and remove that problem from their body, they could later in life have a second independent breast cancer because that broken gene has, it's still there. That susceptibility to cancer is still present. Does that make sense?
Yes.
Yeah. Other questions, maybe? Okay. How are we doing on time? Okay. Okay. Well.
Thank you everyone for coming today.
Oh. Okay.